So welcome to Pulmonary Embolism Grand Rounds. We have a distinguished panel as well as speakers that we'll introduce in just a second. And really the idea here is to have a monthly how-to CME webinar series in the area of both acute pulmonary embolism as well as a chronic, and really across that entire spectrum, diving into pulmonary thromboembolic disease. It's the third Wednesday of each month from 6 p.m. to 7 p.m. So we hope that you join us each month for this event. And the idea is really to learn from each other as we set up interdisciplinary specialized programs in this field. As you know, pulmonary embolism has traditionally been an orphan disease in some sense, in this, because depending on the institution or the microenvironment, different people may be involved. And I think as PERTs have expanded, we see the different makeup of these PERTs, and we can all learn from each other in a very special way and improve the care for our patients. A quick note about CME. This is the QR code. So if you scan this with your phone, I'm going to leave it up here just for a second, and I'll put it back up at the end of the presentations as well. You can scan this, and maybe Craig can send this out as well to the attendees. And if you do an evaluation, then you can get appropriate CME credit for this program. So I will leave that up for just a second as I introduce everybody that we have with us today. So why don't we start with the panelists? So Vikas, do you want to, I know you need no introduction, but do you want to just tell everybody a little bit about you?
No, thank you. Thank you, Sanjum. I'm Vikas Agarwal. I'm an interventional cardiologist at Michigan Medicine. It's very interested in pulmonary embolism, both acute and chronic. And I'm glad that folks are here and they want to learn about acute PE today.
Brandon, please.
Hi, it's so good to be back for these monthly CME discussions. I am a pulmonary critical care physician at Ascension Hospital in Kalamazoo, and I oversee the pulmonary embolism response team in our PE follow-up clinic.
I didn't introduce myself. So I am Sanjum Sethi. I'm an interventional cardiologist at Columbia in New York and the director of the PE team here, and certainly excited to be facilitating this session today, and glad everybody can make it. We have three speakers today. And I'm going to have them introduce themselves each in order. So Dr. Kaja from Michigan, if you don't mind introducing yourself.
Sure. My name is Minhaj Kaja. I'm an interventional radiologist. I'm currently transitioning from UVA, where I was part of the PERT and co-director there, as well as establishing the PERT at Michigan itself. So excited to be here and returning to Michigan shortly.
Amir, please. I believe you're on mute, Amir.
Sorry about that, Sanjum. Amir Darkim, interventional cardiologist at Loyola University. Want to thank Dr. Sethi and Dr. Agarwal for the kind invitation, and want to take the opportunity to share our experience at Loyola, have a sort of lively discussion.
And Rebecca, who is joining us from my institution, if you can go ahead.
Hi guys, thank you for allowing me to be part of this speakers panel today. My name is Rebecca Wiley. I am the patient care director at NYP Columbia, the Interventional Cardiology unit.
All right. There is a hand up from the
I'm sending a message to them on the chat box. So I can take care of the chat box, Sanjum.
All right, perfect.
Moderate the rest of it.
All right, do we want to restart? There we go.
Okay.
So Dr. Kaja, if you would don't mind sharing your screen in beginning, we'd love to hear your talk.
All right. Hopefully you guys can see the appropriate screen. So I'm going to go ahead and start by talking about establishing a successful PERT program and some lessons learned. So here's some disclosures and acknowledgements. Mostly I want to thank my PERT colleagues, including the PERT medical teams at both Michigan and UVA, IR faculty, trainees, staff, and the critical care staff that works with us. So I like to start every presentation with a patient because obviously we're taking care of patients. So this is an example of a 75-year-old female, past medical history of endometrial cancer, which is in remission. She presented to the ED here actually at the University of Virginia with a one-day history of dyspnea, bilateral lower extremity swelling, and palpitations. She was tachycardic, borderline hypotensive with systolic blood pressure in the mid-90s, which was uncharacteristic for her, and hypoxic. She was unable to complete a full sentence. Her initial studies had her white count was elevated. She had a lactic acidosis. Her BNP was 657. Her troponin was elevated. EKG initially showed atrial fib with RVR and right bundle branch block, all of which were new. And of course, this was around 3 a.m. So she quickly had a CT scan performed. And this is what we see on the CT scan. And just to kind of highlight some of the points here, she's got a large saddle pulmonary embolism with a nearly occlusive thrombus in both main pulmonary arteries, RV-LV ratio of greater than 2, and then large clot in transit in the right atrium like I've never seen before, which you can see through these images here. And again, she had the saddle PE. So the question we have now is sort of, what do we do? And so that is really the main focus of my talk, is sort of what do we do with the PERT and how do we take care of these patients? And so this is from an original paper looking at sort of how PE was treated many years ago, and in some places still treated. Is a patient is found to have a PE, and then lots of pages are sent out, and there could be a lot of time that is taken until you hear from the ED, you hear from pulmonary critical care, heme, IR, interventional cardiology, vascular medicine, thoracic surgery, and get back to the ED, and there's delay in care to the patient and potentially catastrophic events. And the PERT process, or the pulmonary embolism response team process, has really streamlined that. But that process is still very difficult to execute at many institutions. And having been a part of 2 different PERT programs, definitely seen a lot of issues along the way. So starting off with patient evaluation as the first step, getting appropriate management of these patients, getting them evaluated in the ED or on the floor, or if they're already an inpatient, is extremely important. Moving on to collaborative decision-making is, again, the heart of a PERT program. Executing a treatment plan in a timely fashion for that patient, and then also having a backup plan, is also critical. And then patient follow-up. So these are all sort of the main points of what a PERT establishes. But going through them individually, so patient evaluation, there are a lot of things that are required in really setting up a PERT program, which one is establishing protocols with primarily the emergency department and the faculty there and nursing staff to evaluate and stabilize the patient. Educating about the pulmonary embolism severity scoring systems, whether you use ESC criteria, PESI score, what have you, but setting up that process. Explaining what sort of history is needed for next steps in decision-making. We may think that this is a very easy thing where we just say, yep, get a history and physical, but if you're considering a thrombolytic treatment, whether systemic or catheter directed, there have been many times where we haven't sort of gotten a history that the patient has actually received or has had recent surgery. And then working on optimizing time from the patient arrival to getting into a scanner, getting an echo if needed, the appropriate labs, and getting anticoagulation started. And all of this takes time, effort, lots of meetings, and getting people on board, which is really important. We want everybody engaged. Collaborative decision-making is a difficult process as well. First off is establishing who should be involved with the PERT. So, whether it's interventional radiology or interventional cardiology, who's performing potential therapies, of course, having your surgeons involved for potential surgical thromboendarterectomy or embolectomy, the ECMO team, When are they called? Of course, the ED, and then the ICU teams of a patient's going to go to the coronary critical care unit or the pulmonary critical care. There's a lot of different steps involved. Getting the word out to the right people, which is all of the potential end users, which is the ED, referring providers in the hospital, the surgical ICUs and whatnot, and how to sort of decide on collaboratively what criteria you're going to use in making your decisions. Again, all very important points and difficult steps that you may have to take and require some negotiation. And then when looking at executing a treatment plan, well, what therapy is the patient going to receive? So that PERT conversation, whether you have a WebEx meeting, a phone call after a page is sent out, who gets paged, who sets up that page, figuring out how you're going to treat that patient, what data supports your decided treatment, and then what sort of algorithm you're going to take for your next step if the patient were to deteriorate. Do you have endovascular protocols in place? Keeping in mind that there are lots of different devices out there, which we'll briefly mention, but do you have TPA at appropriate concentrations? Do you have your anticoagulation decided upon with everyone on board? Do you have protocols within your angio suite as well as follow-up? Is there a surgical and ECMO protocol established, which is something that's important? Having ECMO backup is critical in many situations. And if you don't have that, do you have a referring hospital that you can connect with? Where is the patient going to be housed after their treatment or during their treatment? This is always a critical question. Do we have a bed? We know this with the COVID-19 pandemic. Do we have an ICU bed somewhere? Is it a surgical ICU, a medical ICU, a coronary critical care ICU? Where are they going to be housed in the ED? Where are they going? All very important questions to answer when setting up a PERT. So therapies for acute PE, I'm not going to get into fully, but just note that there are lots of different options. Main treatment being anticoagulation, whether systemic thrombolysis, catheter-directed, ultrasound-assisted, rheolytic, rotational, suction, thrombus fragmentation, and of course, surgical embolectomy and ECMO. So if you are performing endovascular treatment, you have a lot of important other questions to answer. And these are things that we had to decide. Which device are you going to use for which patient? There's so many to choose from. What's the data to support one device over the other in this specific patient? Are you going to use a thrombectomy or embolectomy approach or thrombolysis and leave infusion catheters in? What's the data that you have currently to support it? How do you educate everyone? Referring providers being the first to contact you and use the PERT system. Those performing procedures, we want to standardize the procedures. What type of catheters are you going to use? How are you going to use them? What is going to be the standard protocol? Educating nurses and techs within your angio suite as well is very important, so they understand what type of patients they're going to see and how they're going to treat them, let alone whether you have residents and fellows. And then how do you sort of coordinate and communicate with the clinical team, the ICU team that's taking care of the patient, nursing to help monitor the thrombolysis? Are there complications? What type of complications you're looking for? What to do when a complication occurs? Who do you call? If you don't hear from them, say you page a resident or fellow and the patient looks like they're having a stroke, you'd be concerned for a brain bleed. Who do you call? And then who's the next person you call if you don't get somebody? And then finally, sort of what is your follow-up plan? Where are these patients going to go? Establishing whether you follow them up in what time period with what imaging, who sees them? If the patient has an IVC filter placed, are they going to be seen for that? And setting that up, which we've done in our place at Michigan with the Venous Health Program, seeing everyone at 3 months, getting an echo, and if they do end up developing pulmonary hypertension down the road, then having an algorithm for that treatment plan as well. So just to talk about our patient, we went through the ECMO process, the PERT process. This patient was started on ECMO as she was very ill. We did thrombectomy and then ended up placing thrombolysis catheters. We were able to extract a lot of thrombus initially. And she had right heart failure essentially. 48 hours later, PA pressures were improved, thrombolysis was stopped, 72 hours later, she was taken off ECMO and had completely normal cardiac function. And I've seen her in clinic numerous times, and up to a year later, is doing very well with no functional limitations. This is because we have a PERT program that works. So a summary of a PERT as a management of life-threatening disease complex varies greatly between healthcare institutions and providers. We all have different experiences, but there's a lot of different steps that need to be taken to make this happen, to get a multidisciplinary team approach. And it's really important to provide rapid assessment, consultation, care of these patients with acute PE. Thanks. Finally, there are some outstanding questions as to who to treat, what treatment to choose, what benefit is there, if any, to expect. And this includes randomized controlled trials with the beginning of a HI-PEITHO as one of them, as well as PE track, which is coming down the road. So we'll have a lot more to learn about this. And that's all I have.
Thank you, Dr. Kaja. Really great presentation. Thank you for sharing some of your expertise, and really great a save on that patient. I mean, that's about as high risk as they come, especially with that clot in transit. So it's a great job. Why don't you discuss a little bit of what strategies do you use? You mentioned educating your nurses and your staff. So what strategies do you use to get people from maybe they're new to the cath lab, or maybe they're have been doing coronary work for 25 years, and or in the IR suite they've been doing oncology procedures or other kinds of procedures, and not as familiar with PE? How do you train people with disparate backgrounds to get on board with the PE kind of interventions?
I think that's a great question, and I think one that is always, it's really dependent on the institution. But number one is having meetings in education. So PowerPoint's similar to this, having standardized protocols that everyone gets on board with. And if somebody's uncomfortable with the intervention, is that they have a backup, so that they can learn. So as a faculty member, when a new device comes out, there's always somebody who's sort of the point person. Educating your techs and nurses is important first before you use the device on a patient. I would say that is the key, is not just saying, oh, new toy to use, let's just use it tomorrow. Making sure everyone feels comfortable with it, and then making sure you have a standardized protocol.
There's a question in the chat about what is the data other than anecdotal in support of improved outcomes, and you alluded to the fact that the data is still being developed, and I know we all have our opinions on that, but do you have any comment on where data is at and where data is going?
I would say that there's lots of single arm data suggesting one device or another has an improvement in RV-LV ratio at 24 or 48 hours, which is a surrogate marker, but we do not have real good long-term data other than systemic thrombolysis. And I think the main key here is that the randomized controlled trials that are underway with HI-PEITHO, looking at ultrasound-assisted thrombolysis, as well as PE tract, which we'll be looking at multiple different things, are key to really understanding this disease process.
Amir, do you have any comments there? Because I know you do a lot of research in this space as well.
No, I agree with Dr. Kaja. I think that the notion of having a rapid response team has been very well validated. I think it sort of falls on the PE community sort of design these trials, as he has referenced, to sort of, it's important for us to sort of get this data and to sort of do these trials properly so we can validate what we know is to be beneficial for patients, and sort of understanding which patients need to be escalated, which patients are better served with a conservative strategy, but really having that research focus early on. And I think, as Dr. Kaja pointed out, the PERT Consortium has sort of been a leader, as has been in many centers like yours.
So this is a really good segue. So Dr. Dark, if you would don't mind sharing your screen and so we can hear your presentation as well.
Sure. All right, you guys can see my screen?
Yes.
All right, I want to thank again Dr. Sethi and Dr. Agwal for the kind invitation. I'm going to talk about setting up the cath lab for acute PE interventions with the backdrop of how we sort of built it in our Loyola network. So we have a research grant that it's a disclosure. So like Dr. Kadra, I think it's useful to start with a case that highlights some of the key points that we're trying to express. I'm going to talk about the basics of the PERT team, and I'm going to be a little bit granular on what I think you need in your toolbox as you sort of develop a PERT team and setting up a PERT lab. We'll talk a little bit about quality assurance and what have you. So we'll start with an 82-year-old female who presented to actually one of our satellite hospitals, hypoxemic with abdominal pain, and noted to have elevated troponin, BMP, and the lactate was 2.2, along with a leukocytosis. Because of the abdominal pain, she had a CT, which demonstrated a mechanical small bowel obstruction, but the radiologist noted there was bilateral PEs noted in the lower lung bases. A follow-up CT scan demonstrated bilateral proximal thrombosis with an increase in RV-LV ratio. We did a stat echocardiogram, which demonstrated a significantly enlarged RV with a Connell sign and a decreased RV stroke volume. The traditional parameters were also reduced, as well as TAPSE and tissue Doppler. So the PERT team was activated, and it quickly brought together our team, vascular surgery, cardiothoracic surgery, and pulmonary. And I think that's one of the key points, is sort of having an infrastructure. So this team, we had a conference call, and the strategy at the time was that let's rapidly improve the RV hemodynamics, reduce the risk for general anesthesia, assess the numbers by right heart cath, and place an IVC filter. Patient was taken to the cath IR lab, underwent a right heart cath, had a penumbra thrombectomy, had follow-up hemodynamics and IVC filter placed at the end of the case. These are our baseline numbers. You can see we had a nice improvement in mean PA pressures and a nice improvement in the cardiac index. The patient went to the operating room and was sort of discharged home a few days later. This was the follow-up echo, post-op day 2. So PE teams, like all rapid response teams, have an enormous value. We know that PE is potentially a life-threatening disorder. This sort of collaborative team brings rapidly multi-specialty expertise. It builds awareness in your hospital systems. It utilizes evidence-based algorithms, both for diagnosis, treatment, and probably equally important, standardizing care. Most centers have a PE clinic. It focuses on quality. But really the focus of this talk is how can we sort of set up a cath lab that, as Sanjum was saying, was used to doing, liver procedures or coronary cases, to sort of be ready for acute PE interventions 24/7. So as Dr. Kadra pointed out, the first and most important thing is to be inclusive. So to talk to your hospital system and see who is interested, and be as broad-based as you can. Surgery, pharmacy, the cardiology, pulmonary, I think they all have important roles. And then the next thing is you really want to include your cath lab staff. You want to have members from your cath team on your, give them leadership roles to help build your team. Next, I think it's important, has been previously mentioned, to have algorithms that work for your hospital and your team. So specifically, because we're talking about the cath lab, which are the patients that we need to escalate? You need a pager for activation, and then you have to sort of build in awareness of the program. So what does that mean? That means giving lectures, giving grand rounds, sort of giving follow-up, sending a text, sending pictures. I think this is a very important in our early experience when we built our program. So this is the algorithm that our team put together. We put it all over the hospital. We gave the house staff cards that they can use. As Sanjum was saying early on, PE management was a little foreign, I think, to have a standardized care to most health systems. But that has become far more organized with different guideline base, and you can create your own algorithm that house staff or other hospitalists or what have you, the ER could use. So the next question is, who should get escalated? This is a very important point. There's 2 patient cohorts that I think the cath lab needs to sort of be aware of. One is those patients who come who are rapidly decompensated. They need urgent escalation. This is the case that Dr. Kadra showed, the one that goes on ECMO. But there's another subset of patients that are initially stable, but at risk for acute decompensation. So you have to sort of, have a sense of what is your program? What is your philosophy in your program? So this is a paper that my colleague Eugene Berlowski wrote. I think it's an excellent review of what are some high-risk risk factors for those patients that are initially stable for acute decompensation and mortality. So clinically, a patient who presents with syncope. When I go evaluate a patient, I look at the vital signs. What are they tachycardic? Are they requiring lots of oxygen? What are their biomarkers show? Is there evidence of RV ischemia? Our understanding of echo and PE has come a long way. We use traditional markers like TAPSE and tissue Doppler, but using RV and LV stroke volume can be rapidly obtained. And there has been now several papers looking at mortality. We know risk factors like clot in transit, lower extremity DVT, and ultimately looking at the CT scan. How much clot burden is there? Where's the location? Where's the RV-LV ratio? So I think these are important, variables that your team has to sit down and think through. So when you get that call at 3 a.m. and you have the team on the phone, how are we going to escalate or not going to escalate? What's our algorithm? We know a lot of the clinical scoring systems, have a high negative predictive value, but sort of fall short. And this is, I think, where the research will come in. So the next step is to get your cath lab, get your team together, be inclusive. You have to learn the pulmonary anatomy. So for Dr. Kaja, that's not a big deal, but for cardiologists, it was a big deal. So fortunately, we have people like Dr. Agarwal who gave an excellent talk. It's a resource on the SCAI website. So learn how to study PA angiogram. There's great websites. This is from Virginia, and really know what you're looking at. I think it's for many of us, it was a foreign sort of anatomy, but it's not hard to learn because there's incredible resources out there. The next thing you do, you need a cart, a toolbox. So for instance, I have a CTO toolbox. We created a PERT toolbox, and we have to understand the advantages, limitations, evidence for each device, why RCs have the carts available. So let's get a little bit granular about what is it that you need in your toolbox. So we're going to talk first about right heart cath. So, the right heart cath, I think, is important in those stable patients that are at risk for decompensation based on the variables that your team agrees on. It helps erase the ambiguity. The other value of the PA catheter is that it's a nice sort of catheter to exchange for other equipment, whether it's catheters or thrombectomy devices. So many of you are familiar with this slide. We know outcomes in PE are related to embolism size and cardiopulmonary status. So people with low clot burden can be discharged home. Those that are high risk at TPA. So this is the gray zone that may be normotensive, but they're at risk for decompensation. And I think that's where a Swan catheter erases the ambiguity. So we created a checklist. We have a little book for everything we do in the cath lab, and there's a section on PE. So you need some kind of end-hole catheter. You need some ability to measure pressures. This is easily taught to vascular surgery, IR, who may have less experience than cardiologists in this. You need cardiac output, and you need to document. I think it's important to have sort of very granular data as you look for quality improvement. The next section of your toolbox are going to be TPA strategies. So you need some device to deliver TPA, locally. So when we started our program, we didn't have a lot of sort of institutional support. So we use simple unifuse catheters. They're small catheters. We put the catheters sort of directly into the thrombus, and we gave TPA. So as you may know, there is a lot of sort of data on which catheter is best, but that's not the focus of what I want to talk about. You just need something to deliver TPA. So ECOS is a catheter that has ultrasound assisted thrombolysis, as Dr. Kaja was pointing. The concept is that the ultrasound will fragment the clot, increase the surface area for the TPA to work better. And the idea that to emphasize your cath theme, early on we got some pushback. Why do we got to bring it back? Because you're going to directly infuse the clot, and you're going to use a fraction of the TPA. So in an experienced center, these kind of catheter-based strategies may be really valuable in patients who had high risk for bleeding. This was validated, as many of you know, in the Ultimate trial by Niels Kucher. I think it's important to sort of talk about that in your team. Talk about the data. Why are we using this? The other sort of catheter-based innovation was the Bashir endovascular catheter. So this is a concept of pharmacomechanical thrombolysis. So it's using both a low-dose exogenous TPA and also using endogenous TPA through this basket expansion. This was sort of validated in the Viva Rescue trial, which basically showed thrombus reduction and improved alveolar perfusion. So your checklist that we have is you need a catheter to provide targeted thrombolysis, whether that's an infusion, ecos, pharmacomechanical. You need 5 to 7 fridge sheaths. You need a PA catheter, and you need an exchange wire. So you put the swan up, you get an exchange wire, and you bring these catheters in. You need to have a very good relationship with your pharmacist to help you sort of dose TPA. So we have Epic order sets for all of our protocols. This is incredibly helpful for safety, for the house staff, for our fellows. For TPA-based strategies, you're going to need post-procedure monitoring. So you're going to need a sort of an algorithm where the ICU bed is already requested. We typically will monitor CVC for Vinogen PTT in these patients. This is an example of an ECOS catheter. The next part of your toolbox are going to include non-TPA strategies, so thrombectomy devices. This is incredibly valuable if you have patients who have a contraindication to TPA. So the Extract PE trial was using the device that Dr. Kaja was pointing out, the penumbra catheter. It was validated in this sort of single arm study looking at 119 patients with a very standard but simple endpoint of RV-LV ratio at 48 hours. The other device on the market is the Inari device. It's a much larger catheter validated in the FLAIR trial, looking at the same endpoint of RV-LV ratio. Now, our system, the main hospital has AngioVac. Our other smaller hospitals don't have, but I think it's a useful device for rapid thrombus, particularly in the cava. These are very large bore devices that need an ECMO circuit. So the checklist that we have in our cath lab for thrombectomy is, so a penumbra is a 12 French. So you have to know which sheaths you're going to have. So you have that in your checklist so the staff can sort of look at it right away. The Inari is a 24 French. So it's important to learn the pre-close technique or a figure of 8 suture. I personally like the pre-close technique. It's very easy to learn. I'm sure there's somebody on your team that can do it. We use an Amplatz wire through the swan to deliver these large bore sheaths, and then the device goes through that. The advantage of these thrombectomy devices is they require no ICU setting, but it's important to have groin checks. So this is an example of that sheath coming up for thrombectomy. Hemodynamic support is an important part of your team. So the options are ECMO, Impella RP, or Protect Duo. I've used them all, and they're all very important. And it's important to have a relationship with your shock team, or like, for instance, our smaller hospitals having a direct line to someone who can facilitate this. You don't want to miss that small window before patients acutely decompensate. Like Dr. Kaja, we had an experience where a patient post-neurosurgically coded for 20 minutes. We put them on ECMO, used the Inari device, and the patient walked out of the hospital. The other part of your toolbox will have to be filters. They have a limited but important role. It's important to have a database for retrieval. So you empower your team to sort of track these filters and make sure every one of them comes out that has to. And it's also important to have cardiothoracic surgery as part of your team. There will be some patients that will need to go to the operating room, so you need a rapid opportunity to work with them. This is a person who presented with large PE, had a PFO, had arterial embolitis, was a young patient, and she went to the operating room, had a fantastic result. I would say the last part of sort of building a team that was important for us at Loyola was that we had regular meetings. So we have meetings every other week. We had in-services. We tracked our data. We gave routine feedback to both the staff, administration. We talked about early wins. The staff in general appreciate the opportunity to use these as quality initiative projects for themselves. We have a journal club. With administration, initially we had very little support, but as we had very good success, we improved length of stay. We were showing our research. We got support, and we were able to get some of these more sophisticated devices to help us in critically ill patients. So many of us in the PE world feel that we're sort of on the same trajectory as we had for acute MI. So initially it was just sort of medical management, then TPA, and then primary PCI. And we think there's an important role for a subset of patients to have an endovascular solution if they're acutely decompensating. So I want to thank you again for the opportunity to sort of go over our experience at Loyola.
Thank you, Dr. Darkey. Really wonderful presentation. And thank you for sort of giving us a nuts and bolts of how you go through things. I'm gonna ask a question to our panelist, Dr. Hooks. We've heard now from two interventionalists, and I wanted to get your perspective as a non-interventionalist on how to, from that standpoint, to build a team and the relationship with the proceduralist.
Yeah, I think everybody's highlighted out. That's a fantastic question. Everybody's highlighted out that it's not just one person. It's a team that is real time discussing patients' cases and cares. And to build a successful program, you need input from your team members, your interventionalists, as well as your staff. And there's a lot of training that goes on with it too. Realistically, this is a project that doesn't happen overnight. It happens over several months, and it may happen in a year. But having a close, so as a non-interventionalist, having a very close relationship with the interventionalist is key, as they're essential to provide these interventions if we deem that they're necessary.
Yeah, and a quick point also as well about follow-up. Dr. Akaja mentioned in his talk about how he'd track that patient. Do you have any thoughts about the role and as well as how that becomes additive to the program by having a robust follow-up program?
Absolutely. I think part of the PERT team, especially at my institution, is when they enter the hospital, that's their first introduction, but we don't want that to be their last introduction. We want to make sure that they're guided throughout the process of their hospital stay and through different transitions of care. And that includes hospital discharge. So after they are out of the hospital and they have recovered and do well, they also are referred and established to our PE clinic, which I think is important. The timing of when they come sometimes is often varied by the severity of their hospital stay and acute illness. But part of that PE follow-up clinic too is also addressing some key things as been highlighted in these clinical cases. Presence of IVC filter. Are they getting them out? Are we doing follow-up imaging or follow-up testing of abnormalities that was seen when they're hospitalized? And the other thing too is we're monitoring them after they get out of the hospital for post-procedural complications. We talk about the necessity of interventions and closure devices, but we also want to make sure that they haven't, they survived their PE, but hopefully they don't, have any other complication in response to interventions that we did. So I think that is key, and that is essentially crucial as part of it. And I get it. Some hospital facilities don't have a PE program or follow-up. Just having someone that takes ownership of it and becomes, quote unquote, the champion is an important asset of any PE response program.
That's a great point. You do have to have people that are really invested and do this as a passion and not just as a job, really. And so to segue to that, Dr. Darkey, clearly you are the champion at your institution. And how are the ways that you alluded to it to some degree, but how are the ways that you navigated some of those early administrative challenges? And what were kind of some of the tips and tricks that you can give to somebody who maybe where you were several years ago in terms of getting a program off the ground and things like that?
So I think, Sanjum, I think that the key is to be inclusive. So I remember when Eugene and I started the program, there was a lot of, why do we need this and this and that? But, we built relationships. So I think hearing Dr. Hook's talk, it highlights an important point. It's important to have your non-invasive partners have buy-in to your program. It's important to be inclusive and sort of value their opinion. From an interventional standpoint, it's, I think, critical not to sort of push the procedure, have another procedure. So we had some early wins, and as we got early wins, we started getting significant support from the other clinicians. And we took that sort of early wins to administration. And, I've learned a lot about the business side of medicine. And I think things that are important are length of stay, bleeding events, those kind of things, mortalities. So venous thrombolysis is a significant problem in our health system, and we're able to demonstrate improvement in those sort of very definable endpoints is critical. And I think the way you do that is you have a very clear sort of mechanism for tracking your patients. We use REDCap and we would track it all. So those are the things I would say. I would say, number one, be inclusive, have non-invasive partners, be as broad-based as possible. Don't push procedures, and continue to, when you have a win, just, or you have a publication, email the group, including the CEO and CMO and all that.
That's great advice. It actually, you answered the question in the chat, which was, how to get buy-in from pulmonary critical care for PE interventions, and that's the way to do it. Take care of patients and share what you're doing, and don't push procedures, but push good patient outcomes. I think that's the key.
Yeah, I think, Dr. Sethi, if I could say, I still remember the case that sort of really got us a big win with pulmonary. We had a patient, a young patient who was critically ill. They called us, which they usually don't, and we came and had the patient immediately on ECMO and had a great result. And I think they valued that. I think they valued that that we have a collaborative approach. We're not pushing things, and I think it takes time, like anything else. But I think it's important to sort of not push it.
Yeah, I want to add to that. As a pulmonary critical care physician, I feel like I'm this enigma that's very passionate about pulmonary embolism care. And this past weekend when I was on call, I had similar conversations with my colleagues, trying to convince them the necessity of a procedure intervention, because it varies, right? We all have difference of opinions, and we all choose to isolate which material or guidelines we follow. And somebody had mentioned chest guidelines within the question, but to everybody's point, I think with time, I think there is going to be people that are going to adopt this new approach. It's still a concept that is novel, but I think with each year and each successful case, and including them as part of the team, in terms too of feedback, when you do an intervention, make sure that they're followed up and they know what the outcome was. To close the loop is essential for creating good fostering relationships where they have more confidence in the program and feel more inspired to participate and refer.
Absolutely. Sharing pictures is helpful. So I want to not take too much time away from Rebecca Wiley, who is joining us from New York. And she's going to give us a different perspective as a patient care director in the cath lab, talking really from the ancillary support point of view and some other things that she needs to think about in terms of setting up PE interventions in our institution.
Thank you, Sanjum. So thank you guys for allowing me to join. I'm going to give a different perspective, as Sanjum said. Primarily because my background is in nursing. I've got about 20 years of experience in the emergency room as a nurse, and thought I kind of knew what to do when a PE came through, or a thrombectomy or a thrombus came through in the ER to take care of it. But wasn't it really until I got into this position that I'm in now as a patient care director to really kind of understand the back end of it. So it's really been an eye-opening 2.5 years for me. And so I'm going to hopefully share some of the pearls of wisdom that I have from kind of coming into this role and learning how to manage our interventional cardiology unit when it comes to PEs and thrombus. Let's see if we can get this to go. Okay, so I have no disclosures. I really just kind of want to walk through some different considerations for the group today. I'm going to try not to take up too much time for you, but just kind of looking at different operations, equipment, collaboration, education, teaching, and some next steps that we've put into play here. So operations, some of the things that I have to consider when we're looking at our staffing as well as our case volume is what hours are we running? What hours do you have your lab open? And when you don't have your lab open, who's covering your lab for that day, whether it's in IR or in cath lab? These types of cases are emergencies. Sometimes they come in and we know that we're going to do a thrombectomy or something that's a little bit more planned and not as urgent. So how are we taking that into consideration whenever we're making our daily schedule? We currently run 7 cath rooms in our area, and 3 of them are really equipped really well to do peripheral cases. So when you have those types of cases that come in, the acute PEs, the acute thrombus that comes in, Do you have an open room to be able to put it in emergently? You're always kind of, for me, I'm always kind of thinking of who can I move? What can I do? Who can go into the next case, into the next room, and always trying to stay one step ahead of the game. So on top of that, you're trying to look at planning for how long is your case going to be? Do you have enough time in your day to actually kind of get through that? So those are some of the considerations that we have to consider when we're looking at the operational standpoint of it. And then as far as your weekend coverage and off-hour coverage, these things, like I said, they're emergencies. We kind of laugh here at NYP because we call them a Friday night special, and Dr. Sethi can attest to that, that inevitably these all happen at 5 o'clock on Friday when you don't have the same amount of resources that you might have in your lab at 2 o'clock on a Monday afternoon. For us, we have a single call team, and our single call team will be our responsible team here at Columbia for our STEMI pages and any of our emergency PERT pages that come up. We have not run into a complication yet where we have had double pages at the same time, but we, Sanjum and I are definitely vying to try to get a secondary PERT team for our on-call team. So just some of the operational considerations to think about whenever you're planning your case volume out. Dr. Darkey did a great job of going over equipment, so I won't finesse this a little bit more, but these are the primary pieces of equipment that we use in our cath lab here. As you can see, AngioVac, ECOS, Penumbra, and the Inari Flow Retriever. All of them have very great additions and very positive outcomes when we've seen them used. I think we try to avoid the AngioVac unless it's truly an emergency, because it's a whole complicated other story when you have to get onto that. But we really try to use as much as we can. One thing about equipment that is really important to you when you're planning on it is, does your staff know where their equipment are located? Do they know where to go to get these things? Do they know where to get their catheters? I'm going to take a piece of Dr. Darkey's presentation and make a PE box to go. So we have everything in one location. That's a fantastic idea. Do they know what to use and how to use them? How much of each supply are you going to actually need when you go to use these pieces of equipment? So these are things that, for us at Columbia, we've really kind of walked through. Are we trying to keep them all in a central location? And do we have them available when we know we have the cases? Do our teams know what to use? Do they know what a Penumbra does? Do they know what the ECOS machine does? For our ECOS equipment, Dr. Darkey was also talking about the great relationship with pharmacy. So we don't have a pharmacist in our unit immediately. We have to go to the 4th floor to get it, but we have a great relationship with them. So as soon as we call and say we need pharmacy to create our TPA for our ECOS, they're on it. They have it within 30 minutes, if not sooner, whenever we're ready to go with our ECOS. So really that collaborative effort is really what tries to get us through, or what does get us through and help us to be a little bit more successful. And this has been kind of the resounding theme I think everybody has talked about, is the collaboration that it takes to run a successful program. You have your nursing team members who need to be trained on the equipment. That's probably the biggest portion of it. Your nurses and your techs in the room need to know what equipment they're using and how are they utilizing it. It can't be on day one, you're expecting everybody to be expert users and be able to train the trainer at that point in time. We need to have some education and some real follow through on it. What are your APPs doing? How are they integrated into your cath lab or to your IR lab? How are they taking care of your patients? Are they aware of the patient, what happened with your patient in the procedure? Do they know it? We have electronic medical record ordering. Our APPs are the ones that are ordering our thrombolytics for us. So are they aware of the protocols? Do they know what they're doing from that education standpoint? Have they had that advanced education? Our anesthesiology team, we are lucky enough to have 4 anesthesiology teams in our cath lab at any point in time during the day. Are they on tap to be able to help us with any of these emergent angiovacs? How are we coordinating in that schedule and scheduling that? Our scheduling unit, those are just some things I'm thinking about, like how are we going through our schedule? We go through our schedule as a leadership team every day for the next 5 days. And when Sanjum or anybody calls me and says, hey, I have this case, I try to work through and see where can we get it in and how emergent is it? So you have to have a good collaborative effort with them. Your fellow interventionalists, whether they're in IR or in cath lab, to be able to go through, hey, I need to bump you to be able to move your case to the next thing because I have an emergency coming in. If this is still a relatively new field in your hospital, if you have very distinguished physicians, some of them may not take kindly to being bumped for an emergency, like they don't see the value in this. This is something that we have worked really hard here to have everybody understand what a true emergency is when it comes to this. And we have a very good working relationship with them to be able to make on-the-fly schedule changes to accommodate these true emergencies. What are your residents and your fellows doing? Are they familiar with your equipment? Do they know what they're going to do for care for post patients? How are they going to help flow through the patient through the lab? And then your critical care and your house staff teams, how are they intervening with this? Are we communicating with them? Do we have a protocol in place at your organization to make sure everybody is on the same page? And then lastly, our perfusion team, we've talked about the angiovac, and there's the talk of the impellas and all of the ECMO and all of that. That is another source of need that when you're planning this, just to consider, who are you going to have on tap? Who is your go-to call? Do you have all those resources readily available for you or for your staff on the off hours? Do they all have a protocol in place? Those are all integral things to think about as you're looking at expanding out your program and being able to have a successful program for a PERT. And lastly, a couple of things before I'm quite ready to wrap up is this is kind of just a word jumble, but these are all the things that's really taken us to be able to be successful in our protocols here at Columbia. And as you can see, education is highlighted as the biggest one. So we've spent a lot of time working specifically with our peripheral team, Dr. Sethi, Dr. Parikh, Dr. Finn, on really doing some training of the nursing staff, training of the fellows, training of the PEs. We have a very close relationship with our vendors. I think sometimes they're a forgotten educator because they come in at any time that we need them to do a refresher for our staff, make sure the team knows exactly what they need to do as far as utilizing their equipment. They have saved a lot of headaches for people who are not familiar. They've been a comfort zone for the people who are not as familiar for utilizing the devices, which has been fantastic. We've had some skills days here where people have gone through and hands-on tried to use them. We've looking to have some device champions, so people like on the fly who is really ready to take the Inari flow retriever and teach their peers about it, whether it's a fellow, whether it's a physician, whether it's a PA, et cetera, who wants to champion that device and be our go-to point person here in the lab. These are just some of the things that we've really tried to do here to kind of increase our flow through the lab and our program. And our next steps here, I'm just kind of thinking about it ahead of how are you going to do your community outreach? How are you going to get your referrals? How are you going to do your transfers? Things to think about of who's in your network, who doesn't have an active cath lab or an active IR lab 24 hours a day, 7 days a week, who can refer into you? How are you going to continue to grow your program? For us, we're looking at, again, like I said, increasing our on-call team for our PERT and increasing the PERT team usage in the hospital setting to help visibility. I'm sure like a lot of other organizations here at NYP, during the height of COVID, we had our PERT team consults increase almost 300% here during the months of March, April, and May during 2020. So we're trying to get back into that habit of how are we utilizing our PERT team? Are we getting the activations earlier? Are we able to notify our team members a little bit earlier to help intervene as soon as we possibly can? I know I talked very quickly. I apologize. Force of habit as a New Yorker, but here I will leave it open for any questions. And I also want to leave time for the team.
Thank you, Rebecca. That was really great. You gave us a lot to think about that. I think as the physicians on the call, at least, we're lucky to have people like you that think about those things because we don't always think about those things. So we appreciate it. You at the end of your talk, you actually alluded to one of the questions that was in the chat, which was about ADOC. Does anybody use ADOC who's on the panel?
Yeah,
No.
I can speak to that. I have not used AIDOC, but they reached out to me a few months ago, so with their product and what they're trying to do. I'm all for artificial intelligence and so using electronic tools to make us most efficient. Essentially AIDOC is a software that helps you with interpreting a CT scan and identifying pulmonary embolisms automatically. So it's great for not missing small PEs that would otherwise go unnoticed. So for that purpose, it's something that a few people in radiology would use as a tool to help out their super busy radiologist, in terms of assessment. They are now thinking of, so this company is now thinking of setting up a paging system, which works like the PERT paging system, a conference call. So if you don't have a way to do a Zoom call or a conference call at your institution, then this is one of the many options. So that's available to you. But that's essentially what AI Doc is at this time.
Yeah, I've also been in discussion with them and looked at it. And this is based off of actually looking at brain scans for patients with stroke. So they initially took that and you looked at and changed it to PE. And I think I answered in the chat that, if you get a rapid a CT read on these patients, which usually come from the ED, they're high priority, you get findings and a quick response with the call to the ED, then I don't know that you necessarily need this. Now, especially at a larger center, at smaller regional centers where you don't have, or smaller rural centers where you don't have an on-call radiologist, maybe a Nighthawk service, then this may be beneficial, but it is quite expensive. And I'm not sure if you establish a PERT that you necessarily need it right away.
Yeah, I second that. So we are using the technology mostly for stroke. We have not used the technology for our PE response team activations for just a various amount of reasons. Now I think maybe in time there might be a platform for it, but from a community hospital perspective too, we haven't utilized that. Have you used it, Sanjum?
We have not. We've been in talks as well, and I've seen the demo of it. And I think the theme that I'm hearing and what my impression is as well is that there are multiple ways to set up a system to identify these patients. And this is one of those, and that may suit your particular environment, but it's not the only way to go about it. And there are a couple of people across the country who have had a lot of success with it, but shortening the time to when they're being called, especially when they're starting out. And so I think for those of us who are in more mature programs, we've already set up some of those systems in other ways. And I don't know if it necessarily needs to supplant that. But it's definitely an interesting technology. We're a minute over. I want to be respectful of everybody's time here. Thank you all for your presentations. I'm going to go around the panel and any closing remarks or thoughts about PE or PERT in general. And I'll just from what my screen looks like, I'm going to start with Dr. Hooks.
Yeah, I think this was a great presentation, and it had a lot of key information about setting up a PE response team and fundamentals that we really should have. One of the things I just want to point out, I'm a part of the PERT consortium, and if you're not a part of the PERT consortium, the PERT consortium actually has resources for you. If you are in a hospital that does not have any resources or ability to start a program, we have a PERT partners where you're paired up with members within the consortium that will really foster you some of the questions that have been asked, as well as some of the information provided, identifying areas that you might have challenges. We've all been there. We've all experienced it in different ways or forms in large and small institutions. So don't hesitate at all to be a part of the PERT consortium. Reach out to them for any clinical questions, and we certainly would love to have new members too.
That great point. Absolutely. That we can't say, and the PERT consortium national meeting, I believe, is the last week of September, I believe. So that's going to be another great resource. I think it's in Tampa, if I'm not mistaken.
Yeah, you're correct, Tampa.
Dr. Darkey. I think you're on mute, Amir.
Sanjum, yeah, the second Dr. Hooks that when we started the program, there wasn't a lot of resources, but one of I think pivotal times is when I went to the PERT consortium meeting in Boston. It really sort of laid the groundwork how to build our team, and that sort of consortium has matured, and there's a pathway that is well developed for people starting PERT, and then there's also excellent educational programs like this one. So I think there's a lot of resources and a lot of collaboration, and I think joining the consortium is really important if you want to build a team.
Dr. Kaja.
I would say, this type of educational effort is excellent. A main key is collaboration, communication, and data. And so data with trials for the new devices and or RCTs, as well as looking at your own data within your own program, having M&Ms, reviewing your own internal data and see how you can improve your PERT program, I think is very important. And I'll give a plug for both HiPytho as a randomized controlled trial, as well as the PE tract study, which hopefully will be NIH funded shortly.
Rebecca.
I just say, don't be afraid to ask questions. I think everybody on this call has tried and failed a couple of times when they were trying to get their programs up and going, and rely on your resources. I know that I was very quick, tried to be respectful of our times, but if there's any questions about any of the operational standpoint that you need in your local area or hospital system, please don't hesitate to reach out. I'll answer as best as I can for how we are doing it here at Columbia.
And Dr. Agarwal.
Yeah, thank you, Sanjum, Amir, Rebecca, Brandon, Minaj. These were three of the best talks I've heard on how to set up a PERT program. I agree with everything that has been said thus far, and I would only add that at this time, nobody needs to go through the learning curve as we went through early on. So please seek out for resources. PERT Consortium is great. CME webinars like these and the ones through SVM or through ACC, Sky, and the American Heart Association are also available. And personally, I truly believe that pulmonary embolism and pulmonary thromboembolic disease is the next frontier after coronary disease and stroke intervention in what we do in cardiovascular system. So this is great. We're going to have a recording of this one on the YouTube channel by Michigan Medicine. So for those who could not make it or want to come back and get the CME QR code and the credit, they can feel free to search for this on YouTube. It should be posted in the next 48 hours. So thank you, everybody.
Thank you, Vikas. With that, we'll close. I put the CME credit webpage back up for those who need it. Contact us, please, with any questions. We can get you all of our information. To Vikas's point, there will be a PERT ACC webinar in June, and I can forward that information as well to whoever's interested. Thank you again. Have a very good night, everyone.